Delirium is the next subject from psychiatric section. As a doctor, I can tell you that older patients who are staying for a long period of time in hospital, 50% of them can become deliriant. It's because of many factors such as severe chronic illness, changes in metabolic balance such as low sodium or natrium, medication, infection, surgery or alcohol, or drug intoxication or withdrawal. And because symptoms of delirium and dementia can be similar, input from a family member or caregiver may be important for a doctor to make an accurate diagnosis. And even a patient who is staying in the same room with patient can tell some deviations or changes in behavior. Let's go with definition. It is also known as acute confusional state, which is an organically caused decline from a previous baseline mental functioning that develops over a short period of time, typically hours to days. Delirium is a syndrome encompassing disturbances in attention, consciousness, and cognition. It may also involve other neurological deficits such as psychomotor disturbances, for example, hyperactive, hypoactive, and mixed, which is a classification by other way. Impaired sleep, awake cycle, emotional disturbances, and perceptual disturbances, like hallucinations and delusions. Also, these features are not required for diagnosis. Delirium occurs when the normal sending and receiving of signals in the brain become impaired, of course. This impairment is most likely caused by a combination of factors that make the brain vulnerable and trigger a malfunction in brain activity. Sometimes no cause can be identified. Possible causes include certain medications or drug toxicity, alcohol and drug intoxication, and withdrawal as well. A medical condition such as stroke, heart attack, worsening lung or liver disease, or an injury from a fall. Metabolic imbalances such as low sodium or low calcium. Any imbalance of the electrolytes can induce delirium. Severe chronic and terminal illness, fever and acute infection, particularly in children. Urinary tract infection, pneumonia, any infection especially in older adults. Exposure to toxins such as carbon monoxide, cyanide, and or other poisons. Malnutrition and dehydration, sleep deprivation or severe emotional distress, pain. It's a common factor in the hospital, which declare delirium in patients. Surgery or other medical procedures that include anesthesia. Symptoms. We have many compartments like reduced awareness of the environment, poor thinking skills, behavioral changes, and emotional disturbances. And let's discuss in part every of it. So, reduced awareness of the environment. Symptoms are important for establishing a diagnosis. And an ability to stay focused on a topic or to switch topics. Getting stuck on an idea rather than responding to questions or conversations. Being easily distracted by unimportant things. Being withdrawn with little or no activity or little response to the environment. Poor thinking skills. It's called cognitive impairment, like poor memory, particularly of recent events, disorientation in space, difficulty speaking or recalling words, rambling or nonsense speech, troubling understanding speech, difficulty reading or writing. very confusing state of the patient. Behavioral changes, seeing things that doesn't exist, call it hallucinations, restlessness, agitation, or combative behavior. Calling out, mourning, or making other sounds, being quiet and withdrawn, especially adult older patients. Slowed movement or lethargy. Disturbed sleep habits, reversal of night-day, sleep-wake cycle. Emotional disturbances like anxiety, fear of or paranoia, depression, irritability, or anger. A sense of feeling elated, euphoria, call it apathy, and rapid and unpredictable mood shifts, personality changes. Types of delivery, we discussed it: hyperactive delirium, hypoactive, and mixed. Hyperactive probably is the most easily recognized type. This may include restlessness, for example, pacing, agitation, rapid mood changes, or hallucinations, and a refusal to cooperate with care, with doctors, and with any of the person around. Hypoactive deliriums may include inactivity or reduced motor activity, sluggishness, abnormal drowsiness, or seeming to be in a daze. And mixes, these include both hyper and hypoactive signs and symptoms. The person may quickly switch back and forth from hyper to hypoactive states. And last line, treatment. When delirium is diagnosed or suspected, the underlying cause should be sought and treated. Despite every effort, no cause for delirium can be found. In a small percentage, of course, of patients. Components of delirium management include supportive therapy and pharmacological management. Fluids and nutrition should be given carefully because the patient may be unwilling or physically unable to maintain a balance in intake. For the patient suspected or having alcohol toxicity or alcohol withdrawal, therapy should include multivitamins, especially thiamine. Reorientation techniques or memory cues such as calendar, clocks, and family photos may be helpful. The environment should be stable, quiet, and well lighted. Talking is nice, but medication come into way and deal well with causes that cannot be stable with non-pharmacological interventions. So, low doses of haloperidol when used for short term is the most studied and standard day drug for delirium. Evidence for efficacy of atypical antipsychotics like risperidone, olanzapine, clozapine is emerging with a benefit for fewer side effects comparing to typical antipsychotics. Benzodiazepines themselves can trigger or worsen delirium. They are also used, but doctors should be careful with this administration. Thank you for your watching. Hope this video is useful for you. If yes, you can subscribe and press the button of like. Have a nice day, guys.